I call Dr. Sarita Agarwal to present pediatric refractive error, when and how to prescribe the glasses.
Good morning, everyone. Good morning, panelists. So I will be presenting on pediatric refractive error, when and how to prescribe the glasses. So the contents of my topics are e-metropization, then about the pediatric refraction, spectacle power prescription, and what are the various guidelines regarding the childhood refraction. So the process of e-metropization induces emetropia, that is no refractive error. So it occurs during postnatal development when the refractive component and the axial length of eye comes into equilibrium. The neonates are usually hypermetropic and with minimal astigmatism. So what is the refractive status of the children? So if that's a healthy neonates, these are usually hypermetrope, and at the age of 3 to 5 years, length of globe increases, say 5 millimeters from birth to 3 years. And in adolescent, the childs are mostly emetropic, but if you talk about, there is more myopia than hypermetropia. So in premature newborns, if the birth weight is less than 2,500 grams, these children are usually myopic and sometimes up to -10 diopters of myopia. So at the age of 3 to 5 years, again, there will be a refraction power. And suppose at the age of 5 to 6 years, the child is myopic, so that will be myopia at the later age. And if the child is more than 1.5 diopters hypermetropia at the age of 5 to 6 years, then that child is usually hypermetrope at the age of 13 to 14 years. So prescribing glasses for children, that is always a challenge because of the limited cooperation, then low reliability in vision assessment, and there is always a risk of amblyopia. All the children should undergo vision assessment at least once before the child starts going to the school. And early refraction is indicated in symptomatic cases, like if the parents are complaining of watching television or mobiles very closely. The gold standard in pediatric refraction is definitely a good retinoscopy. But before doing good retinoscopy, you will be very cautious while prescribing cycloplegic drops. Means if you are prescribing atropine, that may cause speech disorder or urinary retention. And it's sometimes contraindicated in cerebral palsy and epilepsy. If you are prescribing cyclopentolate, it may cause dermatitis and follicular conjunctivitis, and it may exaggerate seizures in epilepsy. And if you are dealing with children with neurological deficit, overdose may produce hallucinogenic effects. So how you have to prescribe the spectacle power? So in case of myopia, if you undercorrect it, that might lead to exotropia. And if you overcorrect it, it might lead to esotropia. So you have to be very cautious while dealing such children. So when to consider and what to prescribe, say if the child is, during the first year, if the child is having myopia of less than -5, definitely you have to prescribe the glasses, but reduce the power by 2, undercorrect it, because definitely there is some emetropization occur for the myopes also. And if there is less than -2 diopters of myopia, from 1 year onwards, so reduce it by 0.5 and 1 diopters. And if there is school-age myopia, you have to prescribe the full correction. If you are dealing with hypermetropia, and if you undercorrect the hypermetropia, that will lead to esotropia. And if you try to overcorrect it, it might lead to exotropia. So whenever, now, in hypermetropia, how will you deal it? So if the child is less than 3 years of age and having hypermetropia more than 2.5 diopters, partial correction is done. And if the child is 3 to 4 years age and the hypermetropic power are more than 3.5 or 4 diopters, definitely partial correction is done and you can subtract it 1 to 2 diopters. And in school-age children, full correction is given. And what if you are dealing with astigmatism? So if the child is more than 1.5 years or more than 2 years, and if the astigmatism is more than 2 or 2.5, again decrease the cylinder by 1 diopters up to 3 to 4 years of age. And in school-age children, again you have to prescribe the full cylinder. In cases of anisometropia, and if anisometropia is there with amblyopia, again correct full anisometropia and astigmatism, but correct hypermetropia and myopia as per the age. And after 3.5 years, you have to prescribe it fully. If no amblyopia, there should be strict monitoring. So when there is a risk of amblyopia, or what are the children in which there is a risk of amblyopia and you have to prescribe the glasses for sure. So if the child is hypermetropia at the age of 1 year, more than 4 diopters, or at the age of 2 years, if the hypermetropia is more than 3.5, you have to prescribe the glasses, otherwise there will be a risk of amblyopia. And if myopia is more than -1 or astigmatism is more than 1.5, again you have to prescribe the glasses, otherwise it will lead to amblyopia. So there are certain number of guidelines that have been published for refractive prescriptions by various associations in pediatric age group, like American Associations for Pediatric Ophthalmology and American Optometric Association. And recently, All India Ophthalmological Society has published guidelines for prescription of glasses in infants and young children. So these are the various guidelines, and these are the IGO guidelines, means what should be the power when you have to prescribe the glasses, otherwise that will lead to amblyopia. So what should be the prescription special situation, means if the child is having exotropia, so any refractive error resulting in reduced vision should be corrected to improve the vision. Even the minor amount of myopia should also be corrected, and if there is astigmatism, then full correction is given. In cases of esotropia, full cycloplegic correction is given. In myopia, again give full correction. So why should we stop progression? Because there is always a risk of development of certain diseases like cataract, glaucoma, degenerative retinal diseases, and parents have to bear the cost of optical correction, and definitely for cosmetic purposes. So take home message, 80% of the children accepts full prescription at first attempt, and if the child is not wearing the glasses in spite of sincere attempts, the parents for 4 months undercorrect the glasses, then prescribe the glasses. And first follow-up should be at the age of 6 to 8 weeks after prescribing the glasses, and occlusion should be given next visit. Thank you.
Can I have 2 questions? So what is your experience with these myopia control lenses?
Yes. So whenever the children, I am dealing with the children, means whenever they come to my OPD, if there is myopia, and if the child is, say, less than 2 years of age, then I usually undercorrect it, means, say, if the child is having more than -5 diopters, I usually at first visit, I usually undercorrect it so that child can adapt the glasses. And after he's school going, I prescribe full correction. And in cases of hypermetropia, definitely, if the child is, say, 1 to 2 years, definitely I'll undercorrect it. First, I'll let the child to accept the glasses, then I'll correct it fully. And if there, definitely if there is esotropia, then we have to prescribe the full glasses.
No, madam. My question is about
progressive, this thing.
No, my question is about these. There are companies coming out with myopia control lenses,
Yes.
like a Stellest, and there is MyoSmart. Do you have any experience of those lenses?
Oh, no.
You are not.
No.
To stop progression of
Progression of
myopia.
myopia.
Actually, I usually give atropine eye drops, but I have no experience with those
these
lenses. Sorry.
And there are these many softwares which are coming to control amblyopia.
See, actually, I'm working in a medical college as head of the department, so patients are usually non-affordable. So,
Okay, madam.
thank you so much.
Okay, I have a question. One second. How do you refrain them from mobiles?
Sorry?
How do you refrain the children from mobiles?
Okay.
Mobile
Okay.
uses.
Okay. So what I advise to the parents, if you don't use the mobile, the kids will also not use the mobile. So that is the first thing, which I tell the parents. You have to be apart from the mobile, then only, and if the child, suppose, in cases of amblyopia, definitely I advise the use of mobiles at least for 1 hour by occluding other eye. So he's busy playing games, and amblyopia can be corrected.
Okay, this will be in the amblyopic children. Those who are using and getting the refractive error, no need to.
No, definitely we have to follow certain rules. Like we have to teach the parents about the mobile, means how it could harm
Basically, it is the counseling of the parents.
Yes, definitely, a
If
counseling of the
if
parents.
the children don't see their parents using that,
Yes, definitely. That is the first advice I give to my patients.
same we do. Same we do.
Thank you.
Thank you, Dr. Sarita.